All right, so I'm admitting one more person and we are about to get started. So welcome everyone. I'm really excited today. As you know, this week or March 31st was Trans Visibility Day. So we have a special guest speaker who's going to talk all things trans reproductive justice. But I want to share a little bit about the collaborative, as I always do, in case you're new to us, learning about us, meeting us for the first time, either on LinkedIn or YouTube. I want to share a little bit about who we are. All right. So for some reason, this thing is okay. Here we go. I had to get us situated up here. All right. So really quickly, my name is Dr. Hayes. I am the founder and co-director of the National Collaborative for Reproductive Justice and Innovation in Social Work. Alongside my brilliant co-director, who is not with us this afternoon, is Dr. E. Goldblatt Hyatt, who leads the DSW program at Rutgers School of Social Work. We are building a space dedicated to political education as a tool for liberation in social work. This collaborative exists to do more than inform. It exists to radicalize. We break down the systems that uphold reproductive oppression and provide the knowledge necessary to resist, to organize, and transform our world. Reproductive justice isn't just a framework, it's a political strategy, a survival toolkit, and a roadmap for collective liberation. As the great anti lynching journalist once said, Ida B. Wells, the people must know before they can act. The truth is that truth is at the heart of our work. Political education is about power. Who holds it, who is denied it, and who can reclaim it. Just as Wells used fearless reporting to expose injustice and mobilize communities, we use political education to dismantle reproductive oppression and build a future rooted in justice and self determination. Okay, and that's Dr. Ego Black Hyatt on the screen with me. Okay, let's see here. All right. So, to transform social work into a force of reproductive justice and abolition, we focused on four core pillars of political education and action. The first is building community through political education. We are cultivating a national political education network of social workers, scholars, activists, and organizers dedicated to advancing Black feminism and reproductive justice. Through collective learning, strategy development, and movement based education, we equip communities with the knowledge and tools to challenge systemic oppression and build a future rooted in liberation and self determination. This work is bigger than advocacy, it is about solidarity and collective power. Reproductive justice is not just an individual issue, but a communal one deeply tied to well being of historically marginalized communities. By centering justice, dignity, and radical transformation, we are shaping both social work and movement building work. Two, transforming policy and advocacy. We are dismantling policies that criminalize reproductive decision making and advocating for human rights centered social work. Through political education and reproductive justice lens, we expose the root causes of reproductive oppression, like racism, poverty, colonialism, ableism, all the isms, and work toward policies that support self determination and bodily autonomy. Social workers have too often been enforcers of state control rather than agents of liberation. We are committed to shifting this reality by equipping social workers with the tools to challenge oppressive policies and build a future where reproductive justice is non negotiable. Three, we are working to revolutionize social work education. We are transforming social work education, research, and practice by embedding abolitionist and reproductive justice frameworks into the curriculum. Future social workers must be trained to critically analyze power structures, dismantle systemic barriers, and expand access to reproductive health, rights, and justice. And finally, our four core commitment is we are working to empower social workers to take action. I think that comes through loud and clear through ongoing training, weekly briefings, and radical political education. We hope to ensure social workers have the knowledge, language, and strategies to fight back against reproductive oppression. Social workers are more often on the front lines of state violence and systemic harm. Our goal is to equip them to intervene, resist, and build alternatives. We are committed to empowering social workers to challenge oppressive systems, disrupt harmful institutions, and build a society where reproductive justice is truly realized for all. Okay, so hold on. All right. So to stay engaged with us around our political education, to stay connected, we have a variety of different ways for you to connect with us. If you are on YouTube land or you're here with us live, you can use your cell phone to scan the QR code and you can sign up for any one of our weekly briefings, our webinars, our upcoming trainings, or just to connect with us and get to know us a little bit better. So I'm going to give people a couple of minutes to do that, and then we're going to move on to the best part of this show today, which is talking to Professor Amanda Harmon. Okay, so now let's get to the best part. All right, I am so honored to introduce my friend and colleague, Professor Amanda Harmon. Amanda and I've known each other for a few years now, so I'm super excited that Amanda's spending some time with us. With over 20 years of experience in social work, Professor Harmon has dedicated her career to supporting and advocating for clients through a wide range of life issues and stressors. She is focused on working with the LGBTQIA2S plus community in the last 15 years of her work. Currently, she specializes in areas such as parenting support, issues related to fertility, pregnancy, perinatal, and postnatal experiences, in particular the LGBTQIA2S plus community. Professor Harmon holds all three levels of mental health infertility certificates from the American Society for Reproductive Medicine, as well as having completed the components of care and advanced PMD trainings through the Postpartum Support International. I didn't even know that about you, man, and I've been working with you for a number of years, so this is exciting. Professor Harmon earned a bachelor's degree in social work from Marist College and a master's degree in social work from Fordham University, Woohoo, New York, and Fordham, where they contributed as an adjunct professor, remote supervisor, and faculty advisor. She is currently maintaining a private practice in Trumbull, Connecticut, and is a full-time clinical faculty and interim MSW program director at Sacred Hearts University School of Social Work. So now help me in welcoming Professor Harmon. And I'm going to allow you to share your screen now. So I'm going to stop sharing and now you can share your screen, Professor Harmon. Thank you.
Thank you. And thank you for that introduction. And, thank you really, Dr. Hayes, for all the work that you're doing. We certainly need now more than ever a focus on reproductive justice when, right, reproductive decisions and bodily autonomy is being stripped away from many communities as a faster rate than I think I've ever seen. So I appreciate you. So I usually start, right, because I think not everyone has a base knowledge of the LGBTQ plus community. And so I just kind of wanted to quickly go over, right, when we think about the LGBTQ IA2S plus community, right, we should think of it as sort of an umbrella, right, that houses lots of different pieces within it. So we have pieces that are about gender identity. We have pieces that are about gender expression. We have pieces that are about our sex assigned at birth. we have pieces that are based around who we are physically attracted to and pieces based on who we are emotionally attracted to, right? So we have all of these different pieces that sort of live under this umbrella. But this is also important to note in terms of intersectionality that, right, just because someone has one identity does not mean that all identities housed under this umbrella see each other, and sort of support each other in the same way. That is a variant experience. Um, right, just some definitions. The L in LGBTQ for lesbian, when someone who identifies as a woman is attracted to other women. Someone who's gay, when someone who identifies as male is attracted to other men. Bisexual, when someone is attracted to their own gender or another gender. Transgender is when someone's gender identity does not align with the sex that they're assigned at birth. And we'll kind of get more into that later. Queer or questioning. So, right, where sexual or gender identity does not necessarily meet the societal established ideas and expectations of sexuality and gender, specifically heterosexual norms. 2S, two spirit, which is a term chosen by the indigenous folks here in North America who identify with a third gender, which really implies both masculine and feminine spirit in one body. I will say, so, at the end of the night, I hop on social media real quick to kind of scroll through for the day. And yesterday I saw there was a picture of a robin, and this robin, or a cardinal, and was bright red on one side and had duller coloring on another. And this robin was in Texas and is found to be an intersex robin or intersex cardinal, so that it has bright plumage, which males typically have on one side, and the duller ones, which female cardinals typically have on another side. And in the comments, people were like, "Oh, it's an intersex cardinal," right? Like people recognized that, right, for intersex folks, that there are people who their chromosomes fall outside of whatever is typical, or the right genetic phenotype might present differently. And so those folks don't necessarily fit into a male female box. But what winds up happening, right, is someone delivers a baby and a doctor looks at it and says, to the best of their knowledge, it's a boy, it's a girl. Right. But what does that
Me.
even mean? Right. And how are we making that decision? Asexual, so someone who generally does not experience sexual attraction or very little to a specific group of people, but may still experience romantic, emotional, affectionate relationships and connections with others. Non-binary, so someone who defines their gender and experience outside of these poles of male and female. Gender fluid, so someone who doesn't, yeah,
I have one quick question for you.
sure.
I was thinking as you were talking, Professor Harmon, that I imagine for someone who is brand new to this content, they may be confused between sexuality and gender identity,
Mm-hmm. Sure.
right? So how do you make the distinction between sexuality and gender identity for people who may be brand new to this content?
Sure. So sexuality is really more about, right, who you are attracted to. Right. Whereas gender identity is who do you feel like you are, right, inside of yourself.
Okay,
And so that would be how I really differentiate those pieces.
great. Thank
And
you.
right, in the most basic of ways.
Yeah, 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 yeah. And yeah,
Um,
totally, because I think when people hear LGBTQIA plus, they often don't understand how that relates to gender identity versus sexuality, both.
mhm,
Like, how do they understand it? So yeah, I just wanted to pause there for a second.
sure. Thank you. So gender fluid, right, where someone doesn't necessarily have fixed gender identity. They may resonate with more masculine things one day, more feminine pieces another day, that gender identity versus expression. So expression being, right, how do we show the world who we are? Um, right. And then right, that self-identification process, who we are internally. So gender fluidity is less about, right, showing the world that fluctuation and more about that internal, how are we identifying. Agender, some people who don't particularly feel themselves aligned with a gender at all. And then gender queer, gender non-conforming. So someone who maybe is assigned female at birth, but their presentation in the world might be very masculine, right? Or vice versa. Sometimes think of Harry Styles, who, to the best of my knowledge, has not come out identifying as non-binary or queer specifically, right? But is comfortable wearing dresses, right? Billowy blouses, nail polish. So engaging in what society terms as more feminine presentations. So that might be someone who would be considered gender non-conforming. Um, and the National LGBTQ Task Force has mini toolkits and then a larger toolkit online that are available to download for free. Um, and they have a comprehensive definition section, which even far more than I cover. So if you're interested in learning more about that, I would encourage you, to download that toolkit, to do some reading on those pieces. So aromantic, someone who does not necessarily experiencing romantic attraction, but may have sexual, emotional, affectionate, or relational attraction towards others. And pansexual, a person who experiences sexual, romantic, physical, or spiritual attraction to others, regardless of their gender identity, expression, or biological property. And right, so the plus sign, what's the plus? Right, really, because we are continuing to learn more and more about people and who they are and their belief systems, and that plus, right, allows us to continue to engage in more flexibility, and self-discovery, but still honor that these folks are a part of a community, who are valued and respected. So other terms that you might hear, cis or cisgender. So this is someone who um, they identify as a gender that they are assigned at birth, right? So when I was born, they said to my parents, here's a girl, and I have always felt feminine and like being a woman resonates with me. So I would be considered someone who is cisgender. Gender identity, that inside concept of who we are, right? And how do we identify and resonate with ourselves? Gender expression. So, what do we show the world? Transitioning, which is a process for folks who are trans or non-binary that they go through in their life to live more fully as their true gender. This could include social transition. So that's things like name change, documentation, changing pronouns or establishing pronouns, medical transition, which may include hormone therapy, gender affirming surgeries, and legal transition, such as changing legal name and sex on government identifying documents. But it's also important to note that someone can be trans and not do any of this, right? You've met one trans person, you've met one trans person. Everyone's social and medical transition journey is really up to them. And so if someone says they're trans, right, we respect that. And then assigned male at birth or assigned female at birth. So again, that process of when someone is born and other people are looking at them and saying, this is the box that you fall into.
Mhm.
So how does this connect to reproductive justice, right? So if we think of reproductive justice as the right to have children, the right to not have children, the right to parent in a healthy and safe environment, and bodily autonomy and gender freedom, this impacts all of the LGBTQ plus community, but in particularly trans and non-binary. Right. So some things I want you to sort of think about when we think about the experience of LGBTQ plus folks are, right, where can someone who is LGBTQ plus receive care and receive care in a comfortable setting? Um, right? So an example, a couple goes to deliver a baby and they go to the hospital, and the intake person looks at the couple and says to the birthing parent, like, "Oh, you brought your sister. That's so great." And then that person, right, has to say, "No, this is my wife."
Mhm.
Right? How does that then set the tone for that birthing experience? Right? Then they deliver their child, and they're given the lovely forms that seem to come sometimes for the kids even in your arms that say, like, what's their name, fill this out. And it says mother, father, not parent one and parent two, right? So then how does that impact the birthing and the parenting experience for that couple,
Mhm.
right? And so then you move into other pieces, right, where someone may have transitioned. So let's say someone assigned female at birth has been taking testosterone for, 10 years, right? And they have a full beard, and they've been, very much passing for being man and a man in the world. And they decide that they are going to get pregnant.
Mhm.
um, how does that family building then look like?
Mhm.
And where do they go for that?
Right.
So, right, I just wanted to kind of think for a minute, if you were in those positions, right, where would you go to receive care? What would that experience be like? How would you receive support? Where would you feel safe?
Mhm.
What policies or legislations might help or hurt folks? What community resources might help or hurt? And then also to think about, right, those intersectional identities.
Mhm.
Um, right? We know that trans women of color are far more at risk of violence than a trans person who's white. And we know that trans people, right, are more at risk of violence than someone who's cisgender.
Mhm.
And we know that cisgender heterosexual people, right, are less likely to be victims of violence than someone who identifies as white, cis, and gay. So, right, when we look at those intersectional identities, it's even, I think, more complicated, right, in terms of medical trust and distrust.
Can I just add one thing?
Sure.
And that all depends on whether or not you even have health care.
Mm-hmm.
Right? If you're
Mm-hmm.
someone who is uninsured or underinsured, which
Mm-hmm.
is the vast majority of us in this
Yep.
country, that's another layer of complication, right? How do you
Mm-hmm.
access care? And even if you have the best of health care, it's still going to be expensive.
Mm-hmm.
There still will be, out of pocket costs for it.
Mm-hmm.
Even if you have like all the right people in place, you still financially will have to be situated, in order to afford, the kind of care, that you need. So yeah, this is all really interesting. I also want to add too, me sitting in my cis body here right now, hadn't even thought about the whole parent one, parent two until you just said that. The forms that I had to fill out when my daughter was born as a cis person flew right over my head
Mm-hmm.
until you just said that. And I consider myself an ally. So, the work is constant.
It is, right? A lot of our systems are built with check boxes, right? Versus openness, right? And one of the things that I really had to learn in my practice was I got rid of all the check boxes, right? So on my intake form, it asks for your name and your legal name. It asks for your gender with a line. So you can fill in, right, what you want to, however you identify. I still have to ask for legal name if someone's using insurance, right? Because that's what it's under. Um, but right, a lot of times we just have boxes. And if you are not in a box, right, how complex and complicated does the world get? And how does being outside the box then impact how people are treating you? So those things are, important to consider. So I have here just some different ways that when I was thinking about reproductive justice in the community that I work with. And I want to be clear, right? Like I'm a cis het white woman, um, right? I can't speak for the experience of folks in the community, but I also recognize that I have privilege to take up space in a safer way than other people. So I can share things that, anecdotally people have told me and, right, research that has been done. So I don't want to present myself as the authority on this, right? But just someone who where it is safer for me to sort of speak to this than maybe some other folks. When we think about what it's like, right, being queer in the world, and we think about resources that people may need, right? So medical care. We know that LGBTQ folks are either unemployed at higher rates or underemployed at higher rates. Some of this is because of bias, right, that exists in the world. Other pieces of this might be about documentation. I've worked with folks who've said, I don't want to apply to the job because my legal name hasn't changed yet and I don't look like that name. And so then there's going to be a lot of questions. And so having, right, then being able to obtain employment, which is typically how people are able to get insurance. And then if you look at what type of insurance, right, high copay deductible plans versus jobs that provide more for folks and what's covered under that. So IUI, IVF, these are not guaranteed to be covered. If someone needs to use a donor, right, because they're from a same sex couple, or two folks who both have, right, same reproductive, um, right, organs, that's all out of pocket, right? That's typically not covered by insurance. Um, we live right in a system where you get to the hospital and they, right, check you in and what are some of the first things they ask, right? And part of that is gender. Right. So depending on, right, someone's gender expression and how they're perceived will impact the care that they get. So, we're seeing, right, so there's always been discrimination and bias, but we're seeing an increase in worsening medical discrimination for trans and non-binary folks. Kelly Housk in Tennessee recently spoke about how at 67 years old, she was having incredible pain and wasn't sure what was going on. She went to the emergency room and the doctor who she saw wouldn't even enter the room to talk to her. When they sent her down for like a ultrasound or a CAT scan, she was in so much pain that she was actually falling off the stretcher. She was yelled at, right, by the tech who was assisting her and left on the floor until someone else came to assist her. She is also a trans woman. And so that type of care has been, right, a part of her typical experience that once people recognize that she is trans, she is treated differently. Um, so we also, UCLA School of Law, and there have been reports in Psychological News that have talked about education decreasing in med schools, to MDs and DOs, right, around caring for the LGBTQ community, right? So someone could be a trans man and still need to have a pap smear. Someone can be a trans woman and still need to be checked for, prostate issues. And how are those conversations had without judgment, with care, with support, and with validating identity? A lot of times they aren't. And so, because of these interactions, people are less likely to even seek medical care when it's needed, right? And so, we're talking about basic medical care. We're not even getting into, right, the hormone replacement therapies, gender affirming surgeries, right, reproductive needs, domestic violence shelters, right? So we talk about safety and raising your children in a safe environment. A lot of domestic violence shelters are not set up for queer folks, right? So if someone, if there's a gay man who's in a DV relationship, where is he being sheltered? Where is, someone who has a trans identity, whether they're trans man or trans woman, where are they being sheltered? We see this in terms of inpatient behavioral health as well, right? It tends to be very gendered, men's building, women's building, right? So where does someone who's non-binary stay during an inpatient stay? They have to sort of pick, right? And where's the safest choice? Right? Parenting groups, paperwork at hospitals. So all of these different pieces that when we think about, right, for queer individuals and families, where they're facing additional barriers.
Mhm.
um, Family building, right? So having access to assisted reproduction technology. Right. So for a lot of right lesbian, bisexual, gay couples, as I mentioned earlier, right, they may need to use a donor. That's typically something that, again, right, isn't covered by insurance, so they have to seek that out. Um, in addition, when most folks are going through infertility, if they're using donor materials, then they often have to go for additional mental health screenings. So there's a very popular, very large infertility group here in Connecticut, right? And they, on their website, it says they have a social worker who's a mental health person, but this social worker is actually outsourced and doesn't take insurance. So that means automatically, right, that folks who are may already be under-resourced then have to come up with additional resources just by virtue of not having one person with sperm and one person with egg, right? And now they're being told you have to see this person, because I've had the experience where someone has said, I want Amanda to do the evaluation, and they're saying, no, we're not going to use Amanda. Sorry, you need to use this person, right? So now they're sort of in a place where maybe they could have used insurance with me, but they can't with this person they're being forced to see. And so now they have to come up with anywhere from $200 to $600, depending, how often they need to be seen.
Mm.
Um, if, right, then there's the additional needs of surrogacy. And surrogacy can come into play, right, if there's two men in a relationship and they need someone who's able to carry, but also, for folks who might be intersex and, right, externally they may have a vagina, but internally there may not be a cervix or a uterus. And so that's, a need. They have to pay for that. For trans folks, right? Going off of your hormones can be really impactful, right? In terms of increasing the gender dysphoria. So increasing that disconnect and, right, depression and the struggle of having your body match your identity. But that may be their only resource because they can't afford a surrogate. And we know that surrogacy is, insanely expensive. In the US, it is legal. It's not even legal in other countries, right? So couples are often at a loss and sometimes coming to the US to find surrogates. But you could be talking about $20,000 to $60,000 for surrogates, right? That's a lot of money. Right? And if you don't have either your own wealth or generational wealth, how do you access that? And while there are like some scholarships, there aren't nearly enough for folks in need. And while, right, surrogacy and fertility struggles are not unique to the LGBTQ community, right, it is far more frequent than it would be, right, for cis het individuals. So it's important to recognize, right, how then having this identity, there's automatic barriers that come up, as well as, again, how are you going to be treated by those providers, right? If you're a trans or non-binary person, right? But you are in a waiting room with cis women and people are calling you ma'am or miss, right? How does that impact your identity? What's that like for you when you're experiencing that? Um, So, and then reproductive knowledge and understanding for intersex folks from birth to adulthood. Typically, historically, right, if someone was born intersex, the medical advice would be for the parents to decide their gender at birth, perhaps based on what gender is most prevalent in visualization, and to raise that person in that identity. And yet we see study after study after study that shows someone's gender identity as an intersex person may not resonate with that identity assigned at birth, right? And so best practice would really be to let intersex folks develop how they develop,
Mhm.
right? That to let them decide their identity when they have voice, when they are able to express their agency. And yet we continue to take that agency away from folks. And right, with a lot of the new policies that are being put into place that are saying there's only two sexes, this is the only thing that exists, right? We're not only erasing, right, trans and non-binary folks, but intersex folks from existing at all.
Mhm.
And yet, right, we see lots of different variations of intersex people.
Mhm.
So parental rights in the community. Right in 1996, the Defense of Marriage Act was passed. It wasn't until 2013 with the United States versus Windsor that there was a change in some of that policy, and then with Obergefell and versus Hodges in 2015. And it wasn't until 3 years ago that the Defense of Marriage Act was repealed and the Respect for Marriage Act was put into place, right? Which allows folks in every state who are LGBTQ to be married
Mhm.
and to have all of the rights. That comes along with that. And there's a lot of concern and worry about how does this administration respect or not respect that, but also how does that translate to parental rights? Right. We have things like, you know, reciprocal carrying. So where in a lesbian couple, one partner may be carrying the other person's egg. So they're the carrier and they're using the other person's genetic material. That way they are both feeling that they are physically a part of that process, right? But then upon birth, how is parenthood established? Is it the person who's giving birth? Is it the person's genetics? Are both people allowed on the birth certificate? If folks are married or not married, right? How do are those parental rights established? There are some states where folks have to actually adopt their own child if they're using a surrogate, or if they're using any type of donor pieces, or even maybe the reciprocal piece. So, right, we have to sort of look at how do these systems oppress the LGBTQ community from engaging in family building and recognizing these basic parental, right, rights that they have.
Mhm.
Um, again, in talking about intersectionality, multiple intersectional identities mean that not all, and for some, not any spaces are safe, right? We are aware of, the experience, say we aware, but right, of the history of how Black folks have been treated in medical settings, right? And so I know that for myself, right, a lot of clients, a lot of my friends have talked about that experience where people of color, right? And so then when you add intersectional identity into that, right, how does someone who is Black and queer feel? Right, walking into a medical office. How do those folks, right, feel unsafe in multiple different settings, right? They may feel safer with Black folks, but they're a queer person. They may feel safe in some way with the queer community, but they might be, one of three Black people in a room. So how does that feel? So we can't just assume because someone is a part of one community that they feel safe there. We have to recognize that intersectional identity, but also how that intersectional identity impacts, right? Those interactions with the medical community. Um, Currently we have a lot of laws that are being passed that are increasing, like I said, the fear around reproductive justice issues to bodily autonomy within the trans community. There's been recent legislation that says, care under 19 um, for trans folks, right, that there will be no federal funding for that. South Carolina is trying to implement a ban on Medicaid use at Planned Parenthood because they provide abortions. But Planned Parenthood also provides gender affirming care and gender confirming care for so many people in the LGBTQ community, right? Because of that, right? The barriers that they are facing and may not have access to. Planned Parenthood has been a place that those folks can have access to hormone replacement therapy. Um, there is, I think, a lot of cis women I talk to have the experience of, right, not having bodily autonomy. Like if they want a hysterectomy, being able to have that, right? Or if they want a tubal ligation, not being able to get that. We see the same thing happen in the trans community, right? Where someone who is a trans man or who is non-binary and identifies as more masculine, they do not want to have this experience anymore. And yet there is an unwillingness for providers to do that, right? So not only how does that impact right, their life, but their sense of identity
Mhm.
then. Right. When I have had teenagers who may not have been able to get hormone replacement therapy, one of the places that they often turn to is Planned Parenthood to be able to take birth control consistently for those who are assigned female at birth, right? Because having a period can be very triggering if you're identifying as a man. How does that then come into play in terms of, right, Planned Parenthood? Like South Carolina banning, care being done, period, and specifically with Medicaid use in those locations.
Mhm.
Um, Iowa in February of 2025 decided to take gender identity out of their civil rights laws, right? So now there is no protection for gender identity under that. How does that impact the community? That means that if they go to a hospital, right, and they're being refused care based on their gender identity, they have no basis for a lawsuit. They have no basis for a complaint because we're saying that's okay.
Right.
Right. So then how does that one keep folks from getting care for themselves, right, but impact right, their health, their ability to take care of themselves and their ability to interact with the world. Surveys by UCLA School of Law have, shown that up to 75% of trans and non-binary folks are feeling like they have to change the way they interact with the world. So stop going to medical appointments that they had been going to because they're afraid of having anything documented about their gender identity. Needing to not go out in public because, right, they're afraid of what can happen if someone perceives them as being trans. So we see, a lot of these laws that and legislation that are being proposed really increasing fear in the trans community. And certainly it has made ability also for trans folks to leave the United States even harder now that, right, passports have been, right, either destroyed or not issued in someone's gender identity, that they're relying on, birth certificates where someone is assigned a gender at birth to determine that. But that also means, right, for someone who might be in a state where abortion is illegal and that they need an abortion, right, that they might have the resources
Right.
to go out of country to get that need met, but they may not have the ability to do that because of the documentation. I know here in Connecticut, I think in like 6 more months, we have to get this, like, I don't know, smart ID or something like that to even be able to fly state to state, right? So in the state of Connecticut, they're allowed to have an X as a gender on their license. So if someone is flying to visit family in a state where that is illegal, what happens when they're going through the TSA or when they're going through the state? What happens when, right, someone is trying to seek out gender affirming care, even in the United States where they need to present identification that doesn't align with their gender identity, how, does that impact everyone? So I think those are some, important pieces to consider and talk about. So we talked about, right, barriers to care, building, affirming spaces, and thinking about what's affirming and what is competent.
Right.
So when we think about, right, there are practitioners, medicine, behavioral health places that say, like, great, we accept you for who you are. And then there's competency, which is, right, really getting yourself educated on what are, right, system impacts into the community, what are some of the struggles, what are some of the challenges, learning about the procedures, learning about the barriers to care, cost and insurance, which we talked about, transportation, diagnosis codes, EOBs. So for a lot of people who maybe don't want their families to be aware that they're receiving gender affirming care, but they can be on their parents' insurance until 24, then the EOBs go home. And how does that then impact things? Legislation, certainly small rural communities who have less access to reproductive care. How is that impacting then the even smaller communities for LGBTQ plus folks in there? The bias that exists, both explicit and implicit, right, from large systems to individual practitioners, the harassment that folks face that keep them from seeking out reproductive care, and then IDs and systems.
Professor Harmon.
Yeah,
So this is amazing. Like this is a ton of information.
yeah,
I want to open up for questions
yeah,
before we have to let you go.
sure.
One question that I have at the top of the list is, given that social work is often tied to state institutions,
Hmm.
and many of what you talked about in terms of barrier to care is coming through state institutions, either at the federal level or at the local level. How do we navigate and negotiate that as social workers? I mean, you talked a little bit about what your strategies are as a clinician, which I love. Like you took the boxes off your intake form. That's
Hmm.
pretty easy to do and very simple to do. But if
Hmm.
you're in an agency and not a private practice where they
Hmm.
have boxes to be checked and you're told that you need to use their forms,
Hmm.
how do you overcome those barriers? Like, how do you, as a social worker, operate within state institutions when you want to ensure that, people from the LGBTQIA plus community have access to gender affirming care?
Sure. Right, certainly advocacy, right? So talking to the powers that be within organizations about the impact on clients. Also talking to clients, right? How can they advocate for themselves? And also talking to them about what's going to be happening. So, for example, right, insurances are requiring letters for surgeries for trans folks. I hate writing them, not because I hate writing them for trans folks, but I have to ask questions that make me uncomfortable, much less having folks answer. And so I have conversations with them where I say, right, if this is the surgery you want, these are the types of questions your insurance is making me ask you. And it is hard for me to do that. Are you ready to do that? Are
Yeah.
you ready to answer these questions? Do you feel safe enough to do that? Right. So for them to understand that, right, I don't necessarily have the power to change that, but I can ask the questions in the most sensitive way possible
Yeah.
and prepare them for what those questions could bring up for them emotionally so that they have a space to process that either with me or someone else afterwards, but that they're really ready to kind of answer some of those questions. Um, right. Again, recognizing your privilege. It is, right, safer for me to call up a hospital and say, how do you not have a gender affirming surgeon, right? Than it might be someone who's from the community. So being involved in the community and understanding what are the needs, how can I use my privilege to advocate? But what about people who are more privileged than me, right? So cis het white men who have more economic power, right? How can we loop them into being an advocate, right? Utilizing news resources, when that is safe for people so that word can get out about, the changes that are there. Certainly calling and speaking and showing up to representatives to say, right, this is what we are asking for. But we also have, groups of folks who provide services where we have lists. We have lists of plumbers that we know are safe, doctors that we know are safe, right? Dentists, so places and people that we have vetted, right? Scholarships that are being offered to help people attain that, right? So really working together to build a network that people can access. And so some of it, right, looks like what we think of as traditional advocacy, and then some of that, which is sort of that decolonization, right, um, of therapy. How do we do that? How do we sort of become, right, more abolitionist in practice in our relationship with clients and resources that we offer? How do we make it as safe for people as we can?
Okay, thank you. Now I
Sure.
want to open it up to Lauren, Samantha, or Letitia if you have any questions. And just unmute
Yeah,
yourself while talking.
I have a question. So, Professor Harmon, I specialize in working with women, women's trauma. I think it's really important for therapists and clinicians who are allies to the trans community specifically to identify themselves as that. So I've tried to be really intentional in my marketing and like on my website. I say like I am a therapist for women. Trans women are welcome and celebrated. For people of other identities, if you're interested in working with me, please reach out. I might not be the right fit because I don't have specialized training in working like with non-binary populations, for example. Um, but it's something I think about a lot. And like, is the fact that I practice specifically with women contributing to like trans erasure. So I have like a trans ally, flag in my Instagram bio or the trans flag, and I like describe myself as an ally. But is there anything else you feel like clinicians who don't specifically work with the trans population but want to be known as an ally and supportive and inclusive, what we could do?
Sure. I think, right, it's important to recognize the difference between, right, who we are and how we practice.
Hmm.
Right. I'm not a substance abuse specific focused practitioner. And if someone comes in and that's their primary issue, right, it would be unethical of me not to say, listen, I'm not sure that like I'm the right fit for you. And so I think, right, that that's okay to say that and to also, right, respect with people, right, that if they feel a connection, right, and this is where they want to be, then how can we best support them through that,
Yeah.
right? And whether that's supervision, specialized trainings, right, ongoing competency and care, um, right. But the fact that you're able to say, right, trans women are women and they're welcome here is the opposite of trans erasure,
Okay.
right? And visibility is everything, right? From a sticker on your door to a banner on your house.
Yeah.
Right? All of those things are things that people in the community look for and are able to like say, I'm safe here.
Yeah.
Mhm.
Right. We had someone who was selling cable last year stop by our house, and we have a sign that has hands of all varying skin tones, and it has right, the trans and rainbow flag on it that says all are welcome here. And they were a trans person, and they had said, I just want to thank you for having that because it made me not scared to ring your doorbell when
Yeah.
I have that fear doing my job.
Yeah.
Right. And so it's similar even in clinical settings and in hospitals, right? Do we have openly gay and trans and non-binary people working there, right? Are there flags? Are there stickers? Are there any signs of support, right? Those are, even if you're not explicitly offering a service, right, ways to show support, acknowledgement, and visibility.
Mhm.
Thank you.
Of course.
I was thinking as you were talking, Professor Harmon, about how, in this particular political moment of political repression, and attacks, and fear and all the things, how it's going to drive a lot of people underground,
Mhm.
and make people less likely to either openly declare themselves an ally for fear of, being attacked or, some kind of retribution, but also certainly more importantly, the people who need to gain access to care will go underground and not seek that care out of fear of, being attacked, being harmed, and
Mhm.
it's overwhelming to think about that right now,
Mhm.
which is why I'm so glad to have you here today.
Thank you.
I also have a question. I don't work with this population. I work with seniors,
Mhm.
but considering like you were saying the ongoing climate, like everything is super unpredictable right now, like how how does someone like provide support for these oppressed individuals in this case? Like how do we support them when there's like, you don't know what resources are about to like
Mhm.
go away. It's like
Mhm.
a lot. So
It is. I think the first thing is doing away with toxic positivity.
Mm,
It's okay to not be okay, right? I think a lot of people like strength-based is awesome, right? But if someone's coming in this climate scared out of their mind, saying like it's going to be okay is not necessarily the the
yeah.
best step. Right. So I think acknowledging what's really happening, acknowledging how it's impacting people, acknowledging, right, that the people who we are meeting with are the right, they are the experts of their own lives, and the fear that they feel is real.
Mm,
Um, Right. Part of it is networking and connecting. So figuring out, right, where places and spaces will continue to offer affirming care. So rather than referring people to general endocrinologists, right, I have been referring to two medical centers that are LGBTQ specific and are still offering services. I have found providers, right, in other states, right, who are willing to do teletherapy and provide medication if needed, or telemedicine and provide that medication as needed. I think the reality for the LGBTQ community is they've lived invisibly before.
yeah.
It's right, living out, living proud, gay families, like this is relatively new concept, right, in terms of time. So I think for a lot of folks, and interesting, particularly senior folks, right, like they've been there.
Yeah.
It's queer elders who are really going to help us figure out how to do this,
Yeah.
right? Who haven't had to do this before.
Right.
So it's really those folks who we're going to see kind of saying, like, well, this is what we used to do, and this is how it used to be handled, and doing those types of things.
Mm,
But again, I think, right, finding resources. So where your LGBTQ community centers in your area, right, again, the National LGBTQ Task Force, other online resources who can help sort of help you find people who can provide that, and advocating where you can,
yeah.
right? Like, I would love if they had LGBTQ nursing homes and assisted living,
Oh
right?
my
So
God,
that
that would be amazing.
yeah, so that people can really find community. Right? So, how do we build that for people? When is it safe? How do we do that?
Mhm.
Right? But safety always being first and foremost, and just helping people plan the what ifs, right? Like, so what if your provider doesn't give hormones anymore? Here's a list of people who will.
Mhm.
Right, here's a list of places internationally you might be able to order from. Would your physician still be willing to do the blood work. So things like that.
Okay. Yeah, Letitia just popped in and said, "Oh, I have to go to something else." Okay, that's totally fine. So yeah, we are at an hour. Oh my
All
God.
right.
You are amazing, Professor Harmon. This was
Well,
so good. And
thank you for having me.
I learned a lot myself, quite honestly. I really appreciate this. I'm gonna have to come back to this video over and over and over again and share it in the classroom over and over
Thank
and
you.
over again. So really thank you so much for that. Any parting words for us before you leave?
Anything you need, feel free to reach out and just, right, take care of yourselves when you
Yeah.
need to and keep up the good fight.
Right.
That's
Thank
all we can do.
Okay.
Thank you. I appreciate you for making space for this.
Absolutely. I'll talk to you later.
All right, take care.
Bye-bye.
Bye.